Good morning. I'm Jennifer Morrison. I'm going to talk about Dr. Crisco here for a minute. He's going to present. He's an interventional cardiologist with First Coast Heart Vascular here in Jacksonville. He's originally from North Carolina. His training in medicine began at the University of North Carolina in Chapel Hill School of Medicine. Then he went on to University of Michigan for internal medicine, and then finally he was at Emory University in Atlanta for cardiology and interventional cardiology. He performs catheter-based diagnostic interventional procedures here in the community every day, and today he's here to update us on women and heart disease. He's also the medical director of the Sarah Cannon Institute at Memorial Hospital here in Jacksonville. His talk today is entitled, Fight Like a Girl, Beating Heart Disease in Women. Dr. Crisco?
First, I'd like to thank you for coming out today to the Lunch and Learn here at WJCT. I was engaged by industry here in the community to identify specific topics related to underrepresented populations in cardiovascular disease research and access. And one of those underrepresented populations is actually women. And if you'll just take some time and listen to me, hopefully we can educate you about fighting like a girl, beating heart disease in women. So most talks we begin with disclosures to make you understand that I have no financial interest to disclose, but I wish I did. I've yet to find a conflict of interest with a business or a company and the topic of women and heart disease. I do not specialize in women's healthcare, but at least half of my patients are female. And I cannot rule out the influence of my own Y chromosome in my opinion or my experience. And to give this talk, I am expected to be sensitive to women issues. And I will try my best, but be aware some of this discussion includes references to lightning rod subjects such as body weight and diet. So just bear with me. So when people, when I tell them I'm an interventional cardiologist, the question is, what is that? And what you see here is a heart catheterization laboratory with me positioned here and the camera and the patient. And we deal with the blood supply to the heart predominantly, but I also deal with the blood supply in every other part of the body, the carotids to the brain, the aorta, the kidney arteries, the peripheral arteries to the legs. What you see here is a right coronary artery that's closed and somebody that's having a heart attack, and we, through a catheter, put a wire through here, do a balloon stent procedure to reestablish the blood supply in the setting of a heart attack, and I do this every day, predominantly at Memorial Hospital. This is an image of an artery and a stent being deployed, and the stent keeps the plaque open. I'm an interventional cardiologist. Let's hope you don't need me. I am on staff at several other hospitals, though: Baptist Center, Downtown, Baptist South, St. Vincent South, Orange Park, Memorial, and then Flagler Hospital. So my group covers a lot of territory, and we're certainly here to meet the cardiovascular needs of the community. So this slide sort of represents a background to understand the baseline distribution of the difficulty of this topic. Women are more complicated. Yes, women are more complicated than men. But you have some recent role models that really have helped me generate the discussion here about fighting and beating. They said I fight like a girl, and that's good. Of course, the U.S. women's soccer team, Ronda Rousey, who recently lost to Holly Holm in the MMA fights. But what we have here is a bunch of positive healthcare role models. These are women who are active and are healthy and are focused on athletics. And it does give me a background to say, it's time for you to fight as well. And what you should be fighting against is the #1 killer of women. So the agenda today is to dispel the myths about cardiovascular disease in women, and to first raise awareness of cardiovascular disease as the #1 killer of women in the Western world. And from that, I have a case from just 2 weeks ago that I'm going to show you. We're going to help you identify your own risk. I want you to know your numbers, your blood pressure, your weight, your cholesterol, your fasting blood sugar. And I want you to consider knowing if you're sitting there growing plaque. Plaque's what flakes off and closes arteries down. And that can be done by looking at things like a calcium score. We're here to help you know your inherited risk, but also your contributable risk. That is, activity level, nutritional choices, smoking, exercise, this type of thing. And to help you understand how to lower your own risk. Exercise, weight management, dietary choices, optimize blood pressure, avoiding tobacco products, and optimizing cholesterol. So this is a real case from November 14th, and my day started with a 38-year-old woman waking up at home with chest pain that was unrelenting. 38 years old. Remember this. She has a history of untreated high blood pressure. She's a smoker and a mother of 5. Untreated in the sense that when I saw her when she arrived, I said, do you have high blood pressure? She said, yeah, but I haven't been taking my medicines for 5 years. She goes to the Memorial Hospital emergency room at Kernan and Atlantic, and an EKG is done suggesting an acute myocardial infarction or a heart attack. And in the modern era, that's digitally transmitted to my handheld cell phone. And I look at it, and it looks like a heart attack. And I call them back, and I say, I'll meet you at the cath lab at Memorial Hospital. So I get it. I'm what's called the STEMI doc, and the STEMI doc is the ST elevation myocardial infarction doc. That means the heart attack doctor that day. And so emergent medical stabilization happens at the freestanding ED, but she comes to the heart catheterization laboratory. This is the image of her heart catheterization. This is what's called the right coronary artery to the bottom part of the heart. You have the spine here, the head's up here, the chest is here, the feet are down here. This artery supplies blood to what's sitting in the middle, which is the pumping heart. This is her left coronary system, left main, circumflex, LAD. But what you don't see here is a vessel right here. And this is the biggest of the 3, called the left anterior descending, and it's the missing mid-LAD. You don't see it. So we threw a guide wire, or put a guide wire down the vessel, we balloon it, and we put some stents to open it up. So here's before. You don't see this vessel. Terminates here. This is after. Reestablishing the blood supply. And so what we do is we get a better blood supply to this part of the heart so it doesn't die. And this is all done emergently. Patients are, by the time they get to the hospital, we try to get the artery open on a national recommended before 90 minutes. We're typically below 60 minutes at Memorial. We're very good at this. And this reestablishes the blood supply, takes away the chest pain, saves heart muscle. And the faster we can do this, the better heart function she has, because the longer it takes, this heart muscle is going to die. So, what went wrong here? Well, it's pretty clear she failed to understand her own risk for this type of an event. She failed to address the risk factors that could reduce her risk, high blood pressure management, and she was a smoker. But what went right? What went right was she recognized the symptoms, she called 911, she received modern health care, but what happens next? It's medical care, follow-up, risk factor modification, because if she's already had one heart attack, she's at risk for another one. We want her to help raise those 5 kids and be thankful every day, because sudden death is often the first symptom of a heart attack. People always ask me, how many heart attacks happen every year in your community? And it's statistics were done at one time on this. Only about 25% of people with a heart attack show up at an emergency healthcare situation. That's because 50% die suddenly. Done. 25% stay at home, think they had an ulcer, live through it, seek their health care when they have a problem related to that soon after that. Probably go to their primary care doctor as opposed to an emergency situation. But only 25% call 911 and get to us. So there's a big opportunity if people can understand the symptoms, but also understand your own risk for this. Because if you say, I'm a low-risk patient, it's hard to lower my risk. But if I'm a high-risk patient, I got some risk to lower, right? So here's the myths that we're going to dispel about cardiovascular disease, specifically related to women. Cardiovascular disease is mainly a disease of old men. That's myth number 1. This is data from the American Heart Association, looking at years, 1979 to 2000. In dark blue is the rate of cardiovascular mortality among males, and then in light blue among females. So as a matter of fact, higher mortality among females, but as we see here since 2000 out to 2009, the mortality trends are coming down. And this is encouraging, but the difference here really is where we have some work to do to actually lower them both and make them equal. If you look at this graph, it looks at cardiovascular disease being the leading cause of death among women. And this is per 100,000 population. Coronary disease, both of these are women, but in white it's white females, and in blue it's black females. Coronary disease remains the #1 leading cause of death among women, and it's more than stroke, it's more than lung cancer, and it's more than breast cancer. I could offer to you, though, that more women in their 50s are scared of this diagnosis than they are this one, but again, it's about 5-fold increase among the population to die of heart disease. And then this graph looks at really the age distribution among women of cardiovascular disease diagnosis and annual deaths. Our patient was 38. So even though predominantly death related to heart disease is more common among older women, it clearly is present all the way down in age. And as we saw with our 38-year-old mother of 5, she was a victim of a heart attack. So more than 35,000 women under the age of 65 die annually in the United States of cardiovascular disease. Myth number 2, women don't need to worry about cardiovascular disease before menopause. Historically, there was this concept that the ovaries were protective of you related to your heart attack risk. What the new thinking really is that the relationship between early menopause and accelerated cardiovascular disease is more of a spectrum of risk over time, with menopause just being an event as opposed to menopause going from a low risk to a high risk patient. So as we see, our patient was premenopausal. She was 38, but she had a heart attack. So it's not as if menopause suddenly flips you from a low risk to a high risk patient, but there's a continuum of risk over time. And really, this diagram looks at coronary heart disease progression over decades in time. And this is a vessel, the wall of the vessel, blood going through the vessel, but the development of plaque in the wall of the vessel over time, seeing how in early stage it's mild. As the plaque progresses in the vessel wall, it actually begins to stay there. And it's actually the rupture of this plaque that is the inciting event to close this pipe down and cause a heart attack if this is the artery going to your heart. Alternatively, if this is the artery going to your brain, we call it a stroke. So what you see here is age is a predictor of risk, but also your inherited risk. But these are some of the attributable risk factors over time. Smoking, high blood pressure, elevated cholesterol, diabetes, inactivity, and obesity put you at risk for the development of this over time. So really, the reality is being premenopausal probably does not protect you from cardiovascular disease, and you should be vigilant about your risk at all ages. Plaque calcifies in the wall of the vessel, and this can actually be identified with a CT scan. CAT scans can actually pick up the presence of calcium in the vessel wall, and when the plaque's been there long enough, it starts to calcify. So cholesterol is a number to know, but the vessel wall is where the risk is. This series of pictures depicts the identification of calcium in the wall of vessels to your heart. And what you see here in these specules of calcium that can be picked up by the CAT scan on several planes here, and we look at how much calcium over time. So here's years to an event, and here's calcium score. And what you see here is as your calcium score increases, your event rate increases. So consider getting a calcium score. It'll tell you whether you're sitting there growing plaque or not, and that's the disease that we're trying to slow down. Again, calcium scoring is a CAT scan. It's a test. It can tell you whether you're sitting there growing plaque or not. So today I'm going to give you a bunch of prescriptions. The first one is get some labs done, know your fasting lipid panel, what your cholesterol is, and then consider getting a calcium score, and we can cut this out and you can take it home. Myth number 3, hormone replacement therapy is dangerous to the heart and should not be undertaken in any circumstances. There's a lot of women who are scared to take hormone replacement therapy. There's other women that if you take it from them, they'll kill you, right? So what we're talking about is estrogen, and estrogen, of course, is critical to the reproductive function of both men and women, but it's mostly produced in the ovaries. Some estrogen arises from fat and liver and breast and adrenal glands, and it really has complex physiologic effects and really affects our whole body, the brain, the heart, the ovaries, the vagina, the bones, the uterus, and the breasts. What you see here is sort of the life cycle of the ovarian hormone estrogen over time and the ovarian hormone progesterone over time. And really it increases with age, and this is menopause. We have these big swings in estrogen levels. And really the perimenopausal symptoms I don't have to go into. If you're a woman in the audience, it's hot flashes, insomnia, mood changes, and there's probably 15 other things not listed here. Menopausal physiology is really, it's related to osteoporosis and some other things. So, the question is if I get hormone replacement therapy to calm down these symptoms, does that affect my cardiovascular risk? That's a good question. So the good parts, it does relieve menopausal symptoms. It reduces osteoporosis, that's bone thinning. It reduces fracture rates. The question is it cardioprotective? It does actually change the lipid panel, and we used to think that was helpful. The bad side of it is it does increase breast cancer risk, it changes uterine cancer risk, and it's a complex formulation because we use equine estrogen, that's from a horse, that's what's typically in those pills. So this was studied. This was studied actually out of the NIH-sponsored trial called the Women's Health Initiative, where they enrolled over 16,000 patients, and these are all women, aged 50 to 79, and to get in the trial, you had to have an intact uterus. And they looked at giving you estrogen and progesterone versus placebo, and they followed you over time for about 6 years. The answers and the outcomes were the following. Hormone replacement, that's this arm, was associated with an increased risk of heart disease of 29%, an increased risk of stroke for 41%, it increased blood clotting, it increased breast cancer 26%, but it reduced colon cancer and it reduced hip fractures. And again, this is age 50 to 79 with an intact uterus. So we would only basically draw conclusions relative to this population. So hormone replacement therapy really should not be used to prevent heart disease in the healthy postmenopausal woman. Overall mortality, though, was identical, and the rates in both groups were low. And then, whether this combination in the modern era influences outcomes is difficult to know because they've changed the dose since that study was done back in the 70s and 80s. So then they looked again at hormone replacement therapy, but only estrogen versus placebo. And in this part of the Women's Health Initiative estrogen-only study, they looked at the same age, but with a prior hysterectomy, again, not needing the progesterone, and again looked over 7 years. But here, this study reduced heart disease by 9%. Although it increased stroke and increased clotting, there was no change in cancer, and there were fewer hip fractures. This breaks it down by age group, and what you should see here is age 50 to 59, reduced heart disease, but as we got older, it increased heart disease. So there's really an age-related benefit or risk that should be appreciated. So in younger women, postmenopausal women, with a prior hysterectomy, estrogen alone may be beneficial, is the conclusion. Estrogen therapy is reasonable for the relief of symptoms if started early. Really should not be given to reduce your risk of cardiovascular disease because it might increase it. And unfortunately, by the time this was published, they've changed the doses in all the pills that are out there, so it's very difficult. It's a moving target. So my take home for you today is it's complicated, so discuss it with your doctor. So the prescription today is regarding hormone replacement therapy, discuss it with your doctor. It's really too complex for this forum. Myth number 4, vitamin supplementation is key to preventing disease in women. I cannot tell you how many people bring in every supplement known to man to my office and ask me, does this reduce my risk for a heart attack and a stroke? Well, to tell you honestly, there's only been 2 vitamins studied in cardiovascular disease. I'm going to show you the data. This is the vitamin E primary prevention study, again, NIH sponsored. Why is the NIH sponsoring this? Because no one's going to pay for it otherwise. Let's see whether a vitamin does it or not. 39,000 women age greater than 45 got vitamin E or placebo over 10 years, 636 deaths in one arm, 615 in another, basically the same outcome, not statistically different. And they looked at these outcomes: total mortality, heart attack, stroke, cardiovascular death, cancer, and cancer death. And in a sense, this women's health study with vitamin E does not support recommending vitamin E for the cardiovascular disease prevention or cancer prevention among women. No benefit in reducing CV death. Well, doctor, what about vitamin B? I'm a big vitamin B fan. 5,000 women with heart disease either got vitamin B or placebo, and again, looked at over 7 years, almost the same events. No benefit in reducing the death. These are equivalent numbers. Statistically speaking, no difference. So the reality about vitamins, at least E and B, is that vitamins are probably safe. They're probably not bad for you, but there is no convincing evidence that they need to be taken regularly, and they do not reduce cardiovascular risk. Some supplements, and we've seen this, especially like drugs like ephedra, are downright dangerous. This was common in the 80s and 90s, and there's some baseball players that died suddenly after taking ephedra-containing supplements. Many supplements interact with other medications, and really the entire supplement industry is unregulated. So the safety and purity is entirely in the hands of the manufacturer. And I always ask my patients, is it sawdust or is it ginkgo biloba? Do you know? And the answer is you don't. If it's an unregulated industry, no one's out there making sure that what's in that pill is what they say it is, if it's not regulated. And this is why an unregulated industry is really somewhat of it's like rolling the dice every time you take it. So the prescription for vitamins is no supplement required. Myth number 5, if I'm thin and I exercise regularly, I should be immune to cardiovascular disease. Where's Sheila? She's in this audience. Thin and regularly exercise. My 2 favorite some e-cards are Pilates. Oh, heavens no, I thought you said pie and lattes. My favorite exercise at the gym would probably be judging, right? Now, of course, not everybody in this audience has these opinions. So I pulled up the President's Committee on Physical Fitness, and these are the recommendations that your U.S. government tells you should be doing relative to exercise. Children and adolescents, and I focus really in this discussion on adolescents and adults. Greater than 60 minutes of physical exercise daily is the recommended time. Moderate or vigorous intensity of aerobic physical activity, at least 3 days a week, to include muscle and bone strengthening exercises. And this is the rest of us, 18 to 64. Adults should get 2.5 hours, that's 150 minutes each week of moderate intensity aerobic physical activity, at least 10 minutes at a time, as intervals shorter than this do not have the same health benefits. This should include strengthening activities like push-ups, sit-ups, weightlifting, at least 2 days a week. How much are you doing? That's the question. And I put this slide in here to say, relative to exercise, what's my risk? You know, inactivity and obesity are 2 of the many cardiovascular risk factors, but probably not the strongest. Exercise is great, but not necessarily enough to know your risk. This is the picture of Jim Fixx. Anybody remember Jim Fixx? This guy wrote a book called The Complete Book of Running. He was a big runner, but he started out as a heavy young man who smoked 2 packs a day. He became trimmer, middle-aged, non-smoking athlete, and seemed to ensure a healthy lifestyle, but he died at age 52 while jogging in Vermont. So what does this say? This says his risk increased well before he decided to take up jogging. So this continuum of risk is really what you need to think about. I need to start healthy and stay healthy. And exercise is an important component of it. But one day picking up exercise doesn't reduce your risk if you implanted your risk years before with smoking and inactivity. So here's our traditional cardiac risk factors. The ones you can't modify are your age, your gender, although there's some gender modification going on these days, or your heredity. You can't change that. The modifiable risk factors are really tobacco use, which you can stop or never start. Your cholesterol, we have medicines to modify that. Exercise and diets modify that. Your blood pressure is a modifiable risk factor, even if you inherited. There's medicines to lower blood pressure. Diabetes, the majority of diabetes in the United States is acquired. It's acquired as an adult. It can actually be reduced by staying trim and exercising regularly and appropriate diet. Physical inactivity, all you need to do is exercise more. And really the overweight condition is associated with a lot of these, associated with diabetes, associated with high blood pressure, associated with abnormal cholesterol. And these really are the cardiac risk factors that are reduced with exercise. Exercise doesn't change these, but really people who exercise don't smoke as much. That's been well documented. Exercise lowers LDL cholesterol and raises HDL cholesterol, our good cholesterol, lowers the bad, raises the good. It lowers blood pressure. It reduces the risk for diabetes. And of course, if you're exercising, you're not physically inactive, and it can help you keep your weight in check. So the facts about exercise are really there is a dose-response relationship. More is better. Strenuous exercise is probably better than less strenuous exercise. And several studies have shown that repeated intermittent periods of exercise have a cumulative similar effect to prolonged exercise. So a little bit every day is the same as a lot 3 times a week. So physical activity, the information on it's pretty interesting. Only 1 in 3 children are physically active every day. Less than 5% of adults participate in 30 minutes of physical activity every day. Only 1 in 3 adults receive the recommended amount of physical activity each week. Only 35 to 40% of adults aged 75 or older are physically active. And then of 65 to 74-year-olds, 28% are inactive. More than 80% of adults do not meet the guidelines for aerobic or muscle strengthening activities. And more than 80% of adolescents do not do enough activity to meet the guidelines. Conclusion is regular exercise modifies risk factors for heart disease, and your prescription here is physically strenuous exercise, 35 minutes most days of the week, aerobic with weight training, strength training, weight-bearing exercise, and you can refill this prescription daily. Okay, myth number 6. Most women do not experience chest pain during a heart attack. Fatigue and shortness of breath are much more common. And we've all appreciated, based upon my earlier slide, that men and women are different. But the question is, do they present with a heart attack differently? So the facts are, chest discomfort is the most common symptom of a heart attack, both in men and in women. But women are more likely than men to have additional, non-specific symptoms, which include fatigue, shortness of breath, and weakness. And that's played out in this diagram, looking at the symptoms of presentation of a heart attack, women in purple, men in blue. So chest pain is still a predominant complaint, with men complaining of it more than women. But then when you get to these other symptoms, unusual fatigue, shortness of breath, and weakness, it's really more common in women than men. So we should just appreciate that when a woman comes to the emergency room and says, I'm just not feeling like myself, we do an EKG. We just don't assume that they're having a bad day. And I think healthcare providers, we need to be vigilant about that. It's very clear that if we underestimate someone's risk, we underestimate the appropriate test to do. So that's really a part of why I'm here as well, to talk about the differences in how people come to healthcare. The location of the chest pain, really it's the jaw and the neck that are more common in women than men, but the rest of them are about the same. And then the quality of the chest pain, it's really not that different. The quality is about the same in both women and men. So the facts are men and women present relatively similarly for both genders. It's important to point out is not to ignore the symptoms of these potentially life-threatening problems. It's interesting, women do present at older age, and they have a higher mortality rate when they do present compared to the man of their same age. They actually have smaller arteries, and there's more complications with healthcare among women. And so these are some areas that we can improve on. Myth number 7, chocolate is sinfully bad and should be eaten only rarely. This you're going to love. This could be true, but there's some preliminary data suggesting that dark chocolate may actually be beneficial. Dark chocolate raises good cholesterol. We like that. Dark chocolate improves insulin sensitivity. That means you use glucose better. It lowers blood pressure. It improves endothelial function, which really means it makes vessels work better. Is this clinically relevant? Not sure, but take a dark chocolate bar, 100 grams, 1 bar daily, 30-day supply, and you can refill this as needed. Applause from the audience. There you go. Okay, myth number 8. My diet contributes more to my cardiovascular risk than my size, right? Is it the cheeseburger or the baked chicken? And if I'm running on the beach, but I weigh more than I should for my height, where's my risk? Perception really is everything, you know. I'm not fat, I'm just a little husky, right? So following a healthy lifestyle can really help you, but also your children, prevent or control cardiovascular disease risk factors. Lifestyle habits really do begin in childhood, right? Parents and families really should encourage their children to make heart and healthy lifestyle choices. I don't know about you, but I have a 12-year-old, and, you know, over the last year or two, he comes home, and you know, if I pull out something that's wrapped in a plastic wrapper, he says, Dad, that's not good for you. You know, you should be able to tell what it is without it being wrapped, right? So if it's an apple, it's probably good for you because it looks like an apple. But if it's, you know, processed and in a plastic bag, it's probably not good for me. Smart, you know, children these days. But this is where the risk starts, so this is where the education should start. Really, so you and your children can lower your heart disease risk by maintaining healthy weight, following a healthy diet, regular physical activity, and not smoking. If you already have heart disease, certainly lifestyle changes can help you control your risk factors. So if you have a heart attack, or had a stent, or had a stroke, certainly lifestyle changes are important to control the risk factors for progression of disease. Being overweight increases the risk of the following, and this is really where it's at. If you're overweight, you increase your risk for high blood pressure, you increase your risk for diabetes, you increase your risk for sleep apnea or difficulty breathing, mostly at night, and then abnormal lipids like cholesterol. And actually, being overweight, you know, increases your risk for joint pains, and that's going to limit your mobility. So when people say, you know, is it my diet or my weight? Weight clearly contributes to these risk factors. And if you can't move, you can't exercise. If you can't exercise, you can't reduce your risk. Lifestyle changes really aren't, if lifestyle changes aren't enough, your doctor may recommend other treatments. And I put this up here simply to remind myself about the emerging data on weight loss surgery. If you're morbidly obese, actually weight loss surgery has been shown now to reduce your cardiovascular risk, and so you should discuss that with your doctor. And again, your primary care physician or even your cardiologist can help you find out whether you have cardiovascular disease risk factors and help you create a plan to reduce your risk for heart attack and other heart problems. Children with cardiovascular risk factors really should be considered for treatments with lifestyle modification and failing that treatment. We have data now that inherited cholesterol abnormalities called familial hypercholesterolemia, that really should be treated in childhood, and we have data to support that now. So getting your children screened if you have a high degree of risk of heart disease in your family is reasonable. So the nutritional data is that the typical American diet exceeds the recommended intake levels or limits in the following 4 categories. So we basically get too many calories from solid fats and added sugars. We consume too many refined grains as opposed to the natural grains. We take in too much sodium or salt, and we take in too much saturated fat. This is the Western diet. Americans eat less than the recommended amounts of, this is what we don't get enough of, vegetables, fruits, whole grains, dairy products, and oils. We're talking about the good oils and the low-fat dairy products. About 90% of Americans eat more sodium or salt than is recommended in a healthy diet. Salt's hard to get away from in the Western world. It's certainly what makes you enjoy the food product that's served at somebody's restaurant. Salty foods taste good, unfortunately. Reducing sodium, they estimate, by 1,200 milligrams per day could ultimately save about $20 billion in medical costs. That's a lot of money. And you know, salt really drives high blood pressure. That's what it drives. So a low sodium diet helps control your high blood pressure. So how about comparisons? People always ask me, what should I eat? So I'm going to point to the Mediterranean diet because compared to the typical US diet, it reduced cardiovascular major events by 73% when studied, okay? Mediterranean versus the US diet. The Mediterranean diet really emphasizes primary plant-based foods, fruits and vegetables, whole grains, legumes, and nuts. It replaces butter with healthy fats such as olive oil, uses herbs and spices instead of salt, and limits red meat to no more than a few times a month. Why is this a Mediterranean diet recommended? Because these people live long in the Mediterranean, that's why, and they don't have cardiovascular disease at the same rate. And here is the slide depicting healthy, happy people living longer. 98-year-old man and his wife from one of the Greek islands. This guy's Mr. Moraitis, who lives in Icaria. He's 102. He's famous for partying and makes 400 liters of wine from his vineyard each year. He drinks with his friends. His house is the social hotspot of the island, and his 85-year-old girlfriend is pictured above, right? Makes you all want to move to a Greek island, right? So, the diet recommendation is Mediterranean, fewer calories than you think, daily with laughter, and wine is optional. Refill it as needed. So in summary, and we're getting toward the end here, cardiovascular disease is the #1 killer in the Western world, both of men and women. You can work to reduce your risk for traditional risk factors throughout your life, specifically focus on trying to avoid high blood pressure, diabetes, and avoiding tobacco. Healthy lifestyle should start early and include a focus on children as well as adults. Ovarian hormone therapy is okay in younger women with premature or surgical menopause, and it should be tapered in the early 50s. A balanced diet is probably more helpful than vitamins and supplements, and exercise is beneficial. You should do it regularly. So today we tried to help you understand about raising awareness of cardiovascular disease, identifying your own risk, specifically blood pressure, your weight according to your height, cholesterol, fasting blood sugar. There's opportunity to know whether you're sitting there growing plaque, and that's really a calcium score. We talked about that as a CT scan to pick up calcium in the wall of the vessels in the heart. Understanding your contributable as well as your inherited risk. What risk was I born with, and what risk am I adding myself by my level of activity, the type of things I eat, and whether I smoke or not. And then lowering your own risk. Exercise, managing your weight, choosing your dietary intake, Mediterranean diet, optimizing the blood pressure, avoiding tobacco products, and optimizing your cholesterol. You know, one of the things about calcium scoring, and I mentioned this to a patient this morning, one of the most interesting studies ever done was the recruits that came back from Vietnam that were killed there. A pathologist looked at their coronary arteries. So these are healthy 19 to 25-year-olds that are lugging, 90-pound backs through the jungle. And when they were killed in war, somebody looked at their heart arteries, and they had the beginnings of build up a plaque in the vessel wall in some of the healthiest 19 to 25-year-olds in the country. So this is a disease process that begins early, and that's why I focus a little bit on the children and trying to address their risk early as well. And so, it comes up and gets you when you're 55, 65, 75, and 85, but the disease process builds in the vessel wall early in life. So, today I'm trying to encourage you, fight like a girl, but fight the #1 killer of women, which is cardiovascular disease.